This is a very important question. I think it's very relevant to future of therapy in MDS because in a lot of cancers, immune checkpoint blockade become in some tumors a standard of therapy, and they revolutionize the way we treat patients. In a lot of cancers, when you inhibit the immune checkpoints, you revive the immune response, and this revived immune system can help you to eradicate the malignant clone or malignant cells and increase the survival and make the other treatments also more effective. There is a difference between MDS, AML, and myeloid malignancies, perhaps with other type of malignancies. And first of all, the results of treatment with immune checkpoint blockade weren't that successful and that helpful in myeloid malignancies. Why is that? Might be several different reasons. One potential reason for that is myeloid malignancies are liquid tumors, and the malignant clones are exposed to immune system, so they are not in a confined environment and protected from immune system. So the most immunogenic clones of malignant cells will die and will be eradicated by immune cells early on, perhaps, and the cells that are remaining, most likely, so you have an immunoselection, that you have the less immunogenic clones available. And also they may become resistant to the mechanism that the immune system uses to eradicate them. So generally speaking, the response weren't very convincing so far. But we don't have just classic checkpoint blockade in oncology, and the classical one like PD-1, PD-L1 are the most talked about, but there are others that can be targeted and can be used, which could help, plus combining checkpoint blockade with other type of therapy like vaccination to induce immune response and then prevent exhaustion, or other therapies could in longer term help. Plus in the other generations of checkpoint blockade, for instance, you have TIM3 blockade that could, by blocking that, not only you can revive immune system or prevent Tregs from suppressing immune system, you can also target the malignant cells, because the malignant dysplastic clone in MDS can express TIM3, and by targeting that you can eradicate that clone, or not necessarily eradicate, but at least you can target them. So there are other checkpoint blockade that when you block them, they can remove the malignant clone and also try to revive the immune system. Is it 100%? No. Is it a golden bullet to use and target everything and in one go basically eradicate the disease? No. But I think it's a step towards a better management of immunotherapy in MDS, combining it with other types of therapy, and therefore have a more effective immunotherapy strategies in MDS, which are very much needed in these patients.